Well, good afternoon, everybody, and thank you for joining us today. This is session two of the Lurie Children's Heart Center's Pediatric Preventative Cardiology Roundtable. And we are here with Dr. Amanda Marma Perak, and she will be discussing pediatric cardiovascular health, pushing innovation in research and clinical care. Welcome, Dr. Marma. Great to see
Thank
you,
you.
and
Thank you.
thank you
I'm
for joining
super
us.
happy to be here and really grateful to everyone who was able to join or who's watching this later. I have nothing to disclose other than some government research funding. I think that this is going to be a great opportunity for us to connect and learn from each other. So I want to start by taking just a moment to tell you about my career purpose, because I think that'll help frame what I propose we use this session for today. So my overall career goal is to improve the cardiovascular health and overall well-being of youth and families. And the way I personally like to do this is by creating evidence-based processes, programs, and policies that can be widely implemented by other people. I'll share my main work roles really just to say the reason I have space to create these things is because my primary role, about 85% of my time, is to design and conduct research studies. I do see patients about 10% of the time in our preventive cardiology clinic, and I also hold some leadership roles in the American Heart Association. Now, what I propose that we use this session for is mainly to create a space for open discussion. I want to be able to learn from your perspective. So in the first half of the session, I'll share a few things. So I'll describe how I like to measure cardiovascular health in children using something called Life's Essential 8. And then I'll give a brief overview of a couple of studies I have running that might be relevant for some of your patients. And then in the second half of the session, I'd love to start a discussion with you. I want to get your feedback, your input, and then, of course, whatever else is interesting to you, we can certainly talk about.
Dr. Marma, I would like to remind everybody that they can put in questions in the chat room or in the Q&A area. And then since it's a smaller group, like 6 or 7 people, I'd like to encourage people to raise their hand and I could unmute you and you guys could have
Perfect.
a discussion. Okay. So I'm gonna let you go ahead and take it away. I'm gonna hide my mug here and let you take it away.
Terrific. So let's start by getting on the same page about how we can define and measure cardiovascular health conveniently, or CVH for cardiovascular health is what I like to call it. So I like to use Life's Essential 8 metrics, which are both pictured here and listed in the table. This is a construct that's officially been put forth by the American Heart Association, and I had the pleasure of serving as the pediatric expert when we created this definition. So we define CVH using these 8 factors for health behaviors: diet, physical activity, sleep, and nicotine exposure, and for measured or clinical factors, including body weight, blood pressure, lipids, and blood sugar. Hopefully nothing too surprising there. Each of them is measured in an age-appropriate way and then scored from 0 to 100 points, where 100 points means that the child is, or adult, in either case, is meeting optimal guidelines for that metric. So for example, a healthy diet is defined by adherence to the USDA MyPlate pattern. You can then take the average of whichever of these 8 metrics that you were able to measure and score, and then you get an overall or total CVH score of 0 to 100 points, which you can categorize as shown there at the bottom: low, moderate, or high, based on the total points. So I like to use this CVH construct in my research, but I also actually use it in clinic for some of my patients. I think it's a really great way to bring together all of these related factors so that when you're talking to families, it's really one coherent story about heart health. It also gives them a lot of different entry points. So it's accessible, places for them to improve, ways that they might be motivated. So for example, let's say you have a teen who's really dead set against giving up fast food with his buddies. I hear that all the time from my teenage patients. And maybe he doesn't really care that much about his body weight or BMI. He's not concerned. But in talking to him, he is interested in avoiding diabetes because it runs in his family. And he's willing to increase his exercise a little bit. So now you've gotten in. So this combined construct of CVH based on Life's Essential 8 has been extensively studied, thousands of studies at this point, and having better CVH is clearly associated with a huge number of benefits for both adults and children. I've listed some of them here, and I just want to point out a few. So it's not just heart outcomes: all-cause mortality, cancer, depression, quality of life, healthcare costs, and others. Really a wide variety of things that we all would like to have. But unfortunately, although probably not surprising to any of you, we're not doing great with CVH. So just about 20% of US adults have high CVH, and among youth, it's actually not that much better, just 29%. I want to make just one more point about how CVH is defined. So with you being clinicians, you know full well that the drivers of CVH are really complicated. And when we created this CVH definition, we also acknowledge that psychological health and social influencers of health are really root causes of poor CVH for a lot of our youth and families. So while those two factors are not named as one of life's essential 8 metrics, they are treated as foundational factors that we just have to consider and address anytime we want to talk about CVH. So this is really all I wanted to say about CVH for now. I put a QR code up top where you can get some more information about Life's Essential 8 from the American Heart Association website, and I'm certainly happy to take further questions now or at the end or follow-up emails. But I want to go ahead and move on and share a little bit about a couple of the studies I'm doing that could be relevant for your patient population. And again, as I'm talking, I really want to invite you to drop your feedback and ideas in the chat, raise your hand, or hang on to them. We'll return to them during the discussion, or I can at least, look over your comments later on. So the first of the two studies is called the Heart to Heart study, and it's all about getting babies off to a healthy start. The rationale for this study is that we already know from big epidemiologic data that maternal CVH during pregnancy is strongly associated with birth outcomes as well as childhood outcomes such as CVH during adolescence. But despite that, clinical trials that start an intervention during pregnancy to try to improve maternal CVH really have not panned out. So in some cases, they have actually been able to improve the mom's CVH during pregnancy, but they really have not improved the child's outcomes. Personally, I think that part of the problem is that we need to do a better job of addressing those psychosocial drivers that we just talked about. But I also think that there could be a timing issue. This figure shows fetal development from a single cell before pregnancy all the way to full term. Most pregnancy interventions start here at about 20 weeks or at the earliest, maybe 13 or 16 weeks gestation. But just looking at these figures, you're reminded that most of the action is actually here. So between conception and about 10 or 20 weeks. During this time, the baby's organs form and the metabolic controls for growth and development are established. So we may actually be missing the most important window to improve maternal and child CVH. The challenge, of course, with intervening before pregnancy or even very early in pregnancy is finding those future moms. Because in the US, about half of all pregnancies are unplanned and more than half are unplanned among socially disadvantaged groups, the same ones who have the poorest CVH and need the most support. But of course, you all know better than anyone, primary care clinics see lots of future moms and very frequently because many of them currently have kids and then end up having more down the road. So studying interpregnancy, I think, will be a really useful first step to find out if preconception is really where the focus needs to be. So that's what we're doing in this study. We're trying to close that gap between our current understanding and getting to a place where we can build an effective intervention for both maternal and child CVH. So the specific aims of this study are to first understand the key timing. Is it the health of the mom before, during, or after pregnancy that matters most for the child? And then second, we want to dig into those social and psychological drivers. And third, we want to talk directly to the parents and to clinicians like yourselves to find out what they think is important and would actually value in a program to improve the family's CVH. This is a brief overview of the study design, really just to emphasize that this is a pragmatic, low-burden study. The entire thing is going to be virtual with no in-person visits required, and that's how we expect we'll be able to enroll a more diverse sample. So we're going to start with kids. We're going to find moms who already have kids in the 0 to 5 age range because these moms are statistically more likely to have another child, whether they plan it or don't plan it. We'll enroll about 5,000 mothers and then do an initial round of surveys about their CVH and psychosocial factors. And we anticipate that about 650 will actually get pregnant and deliver another child during the study. For those families, we'll do some additional surveys of the moms as well as biological dads and social co-parents and about the new baby all across pregnancy and postpartum. And we'll also gather their medical record data on their health factors for all of those involved family members. And we'll be able to that way calculate their total CVH scores. And then again, we're also going to invite some moms, dads, or co-parents and clinicians to participate in those interviews I mentioned and share their perspectives on what might work for them. So we are expecting to start enrollment in just a couple of months, and that's where all of you could potentially come in. So most of our recruitment will be through direct methods, so messaging patients at Lurie and Northwestern, but we would very much welcome clinics to participate by posting flyers about the study so that any interested families in your practice could reach out to us and potentially enroll if they are still interested. So at the end of my slides today, I'll have my email as well as my lab website for more information. So now let's move on, and I'll share a little bit about my other big study, or really a set of studies called the CVH Promotion Program, or CPP studies. This group of studies is all about creating a program to improve CVH in teens who already have cardiovascular risk factors, so high blood pressure, high cholesterol, high blood sugar, prediabetes, that sort of thing. I'm focused on teens in this project because I think there's a huge opportunity, but also a lot of gaps here. So for the opportunity, as you know, in primary care, this is really a critical chance to catch these teens, these emerging adults before their lives completely change. They might graduate, move out, maybe have a family, and then a lot of times they get lost from clinical care for a period of time. The other opportunity here is that teens are starting to develop some self-regulation at this age. So any intervention that we do might have a better chance to work now that they have a little more self-regulation than when they were younger. But on the other hand, there are also some major gaps for these teens. So as you, of course, know, for just one of these metrics, obesity, the USPSTF recommends that we should provide at least 26 contact hours and preferably more than 52 contact hours of intensive behavioral intervention if we're going to make an impact on their cardiovascular risk. But you also know how infeasible this is. The demand for care is far greater than the supply in terms of the high risk factor prevalences. These interventions are highly burdensome to families, and so access is a problem, especially for our lower resource families. And moreover, teens don't really engage that well, and they don't have very good outcomes compared to younger kids. So the CPP studies are trying to improve both efficacy on the one hand and accessibility and scalability on the other hand. On the efficacy side, there's lots of data to suggest that for teens, you can't just talk about diet and exercise. Emotion and self-identity are key mechanisms that drive their behavior. So for example, we found that CVH scores were much lower in teenagers who had high depressive symptoms compared to teens who didn't. And you're probably familiar with the figure below. This is from Erik Erikson's Stages of Development, where the very essence of adolescence is to grapple with self-identity versus role confusion. We also sense checked this through interviews and surveys with a variety of teens and their parents, and they completely agreed. So teens said that sadness and stress, for example, drive my poor eating, and parents selected mental health as the #1 most important health factor for their child, their teenager, far and above any CVD risk factor. And this was not just serious mental health diagnoses like depression. Parents also rated things like stress management and self-love as critical for their teen. So CPP is trying to address both emotion regulation as well as self-identity to aid in behavior change. And then over on the accessibility and scalability side, we're designing CPP to be completely virtual and actually mostly self-guided by the teen through online lessons and assigned practice without a need to involve their busy, over complex lives parents or their clinicians. They're still going to get that important human contact and guidance via one-to-one coaching from trained coaches and virtual support groups. As I mentioned, we're doing a series of studies to design and evaluate CPP. So right now we're doing the CPP design study where we're working directly with 12 diverse teens back and forth to get their detailed feedback and input on how to make all of these pieces of the program maximally engaging and effective for them. The next step will be the pilot trial, which we anticipate will be launching in this coming fall or winter. And again, this is where we're going to want to reach out to you. So hopefully you'll be able to, at that time, refer any of your teenage patients with cardiovascular risk factors who are interested in improving their CVH. And then after the pilot trial, we'll be ready for a full-size trial to really optimize CPP for efficacy and cost so that we can build that best intervention possible. So I'm actually going to stop there because I really wanted to have a chance to hear from all of you. I've listed here just a few ideas that maybe could start our conversation, but I also want to ask you to please reach out via email, check out my lab website with any ideas, questions as far into the future as you like. I'll quickly mention that if you go to the website today, it's still under construction. So over the next few weeks, it'll sort of fill out and look more complete. But definitely love to hear from you anytime and looking forward to the discussion now. Thank you so much for your attention.
Thank you. This was super informative. A lot of things that, as someone who works at Lurie, didn't know. Some of the stuff that you're offering here. So it's really neat. So have some questions piled up here. But for those of you that are in the audience, if you want to ask question live, feel free, raise your hand, or just go ahead and type in the chat and we will read it up for you. But some of the things that we have here is the first one is on your trials. Do you have a flyer that you can share or we can share?
Yeah, absolutely. We have flyers. So the CPP design study has already enrolled to completion. The pilot study won't be launching for a little while, so that flyer won't come for a bit of time. The heart-to-heart study that we're launching in a couple of months, we have a flyer that is going through IRB approval. So certainly once that's available, we'll get it posted on my website and I could share it with you, Chad, if you wanted to distribute it.
Yes, that'd be great. Because once you have that, I will go ahead and share that with everybody, and
Perfect.
we can do that. That is wonderful. So, question came with the beginning of your presentation. With so many different diets out there, and what did I say here? So many different diets out there that that are used to help with different disorders, such as keto with seizures. Does keto and paleo worry you with CV issues?
Yeah, it's such a great question. I think we're talking about children here. And so there's been a lot less research on the cardiovascular effects of diets like that. So certainly if there are seizures or some other medical indication for following a restrictive diet like that, then certainly with the guidance of your physician and registered dietitian, that's what I would always tell my patients. But I certainly appreciate the question because now a lot of these things are popular. And so personally, when I'm giving guidance to my patients, it's always much more about balance, long-term changes that they're going to be able to sustain, not doing anything that feels really dramatic, especially in children, right? Because as the question points out, kids have really robust requirements for nutrition, for energy to be able to grow and develop. And we just don't know what the effects of those things would be. So I do try to steer my patients away from those by giving them that information that we just don't know. Like the one exception I would say is intermittent fasting. There have obviously been some studies in adolescents, and in the short term, it appears to be safe, although it doesn't obviously produce better results than a more moderate way of, restricting calories or otherwise improving diet quality. But I don't like I never force my patients prematurely to give up on intermittent fasting because I think, especially for teens, as all of you know, like they need to have their autonomy. And so it's more of a back and forth discussion about potential risks and, okay, well, how does your body feel when you're fasting? How is your energy? Like what tends to give you more of the energy you need for schoolwork or for sports for many of them? So often I find that that can be helpful in the discussion.
Now, with intermittent fasting, you touched on in utero fetal health here, and how is there an effect there? Like,
Yeah. Great question. So that's another area of investigation, and people are really hesitant to randomize pregnant people to an intervention that restricts their nutrition in any way. So people have looked at things like, just observationally, the nighttime fast, like how long a mother goes at night without eating. And there's some observational data that having a shorter period of time without eating can actually be, harmful for the mom, for her cardiovascular health, which makes sense, right? Like if the mom's up eating late and getting up early eating. So first of all, she may not be sleeping enough. Second of all, most of us eat less healthy when we're eating late at night. But there have not been, to my knowledge, great controlled studies that have looked at maybe short term, but we're interested in long term, right? Like we want to know whether there's going to be any long term effects on that fetus because of the whole developmental origins of disease hypothesis that in these natural experiments where countries experienced famine, babies who were in utero during the famine ended up having obesity and cardiovascular disease because it was sort of like their body adapted to that and it was maladapted for the postnatal environment.
Hmm.
So for sure, just like with kids, you have to tread a little bit more cautiously with pregnant people.
Absolutely. And, with keeping on this subject with fetal health, as you know, we have our Institute for Fetal Health here at Lurie Children's, and they work with a lot of OBGYNs, of course. What's your relationship? Do you work with them with these studies? And I'm
Yes.
curious to hear that.
Yeah, absolutely. So, for example, in the heart to heart study, I work very closely with an MFM investigator. I think that
Hmm.
that perspective is critical, right? Like you have to know what are the pregnancy considerations anytime you're studying around this time. I work with other pediatricians. I work with experts on fatherhood
Hmm.
and on diverse family structures. I work with behavioral intervention experts who know all about different theories of behavior. I work with people who have a lot of focused expertise in social influencers of health and traditionally disadvantaged populations. So for sure,
Right.
these research studies are bringing in perspectives from all different places.
Okay.
And I would love
Um,
perspectives from people on this call. So
right.
just another pitch to hear from you all.
A- Absolutely. The healthy plate method. Um, this is my question. First of all, I loved your video. You had a nice little healthy plate video that was put out there. And I will be sharing with everybody so you can see her healthy plate method. Is there flexibility to that? I'm a dad, right? I got kids and they hate, the foods that I put out there. So is there tricks that you can,
Yeah.
because the folks who are watching this video are all going to be pediatricians, right? These are going to be some curious parents who want to see the
Yeah.
video here. So
Okay.
do you have some tricks to kind of fill up that healthy plate that may, for those kids who are picky eaters?
Definitely. Yeah. I do. And actually, Lurie's blog this month has some of those tips included. So if people want to check out that blog, I consulted with the blog writer and helped develop that content. So some of these are summarized there, but I would say number one, I always encourage making it a routine and an expectation for the whole family so that it just becomes part of what we do. Number
Hmm.
two, with regard to picky eating, you can try giving the less preferred food first. And so let them have the vegetable before. But the other thing I would say is that um, I personally recommend to families that for vegetables, a lot of kids have restricted taste around vegetables and they might come in and say, he just refuses to eat vegetables. But every time, I will tell you, every single time when I dig in and ask the child, like, okay, I get it. You don't like vegetables, but like, what are the vegetables that you're willing to tolerate that at least you don't throw up or gag when you put it in your
Hmm.
mouth? And they can always name at least one, always. Like, there's never been a case where they couldn't. And so okay, start there. Fill up your my plate with just that one vegetable. If the only vegetable you're willing to tolerate is raw cucumbers, I let that pass as a vegetable. Then half your plate at lunch is going to be cucumbers, half your plate at dinner is going to be cucumbers, and then mom and dad, you guys be eating whatever variety of vegetables you like to eat and let them try it because over time, many times they do become a little bit curious. Like you look like you're really enjoying that veggie over and over
Hmm.
again. Like maybe I'll take just a little taste. So personally, I think that's a happy medium. I don't ask families to force a vegetable on a child that they really hate. It's more about finding what they are willing to eat, work with that to get in the routine of having those vegetables, and then expand it over time.
Okay. Um, one more question I have before I want to go into the heart study and the CP study. What about nutritional shakes as a supplement, not to replace a meal, but to kind of add on to that? I know there's just so many out there. Is there anything to look for with stuff like that?
Yeah, definitely. Good question because parents sometimes have that question. I would say that I sometimes see that from teenage boys who are wanting to take protein supplements. And I always say, we know much more about the long-term health effects of complete foods.
Right.
Protein shakes, they might be the healthiest protein shake on the market. And often I'll say, look for what the sweeteners are, whether it's artificial, natural, how much sugar, if there's sugar, what
Hmm.
other chemicals, weird things are in that
Right.
protein shake. Um, but I think we have pretty good reason to believe that processed food in general is not as healthy for you as unprocessed food. And so I always encourage them. Plus, it's like a sustainability thing, right? Like, are you going to do protein shakes your whole life? They're
Hmm.
expensive, they're inconvenient. So
Right.
trying to get them to appreciate and enjoy real food is my first priority. But in some cases, like they're just not eating protein, and protein is so important for satiety, for growth,
Hmm.
And so in those cases, sometimes they will want to use protein, and then I look at the label with them and I try to help them
Hmm.
figure out how to use it consciously. In general, I do try to have families work on eating whole foods, even when it comes to like homemade shakes. So a lot of families be like, oh, we're doing so great, we're doing smoothies all the time. But there's
Hmm.
something different about smoothies, right? Like you can put 5 bananas or 5 apples into a smoothie and drink that down pretty quickly. And the fiber is all mixed in. So it
Hmm.
doesn't hit your belly the same way that eating 5 apples would.
Right.
And so
You're hungry half an hour later,
yes, yes.
right?
So
Yeah.
especially for weight loss, I find that, and I've had some anecdotal evidence where people were doing smoothies and then gained a bunch of weight. And so I always encourage them to work on eating whole foods.
Hmm. Thank you. So as we get ready to wrap up here, your two studies, if people have more questions about them, once that we get the flyers ready and send them out, can they email you directly? Are you
Definitely. Yeah.
okay?
Email me, or if you don't want to send an email, you can go to the website, find information there, but I would love to hear from you. So please do email me personally anytime.
Right. And then these are so great, and you're willing to. It seems like you're willing and you want to have ongoing engagement with our community providers. I would love to set up some one-on-one, maybe virtual meetings with you so you can meet some and ask some questions.
Sure, happy to do that. And I'll also mention that I'm part of the whole preventive cardiology program. And I also am just interested, as I said in the beginning, in creating systems that are good and helpful. And so even if it's not related to research, if there's just a headache that you have in interacting with preventive cardiology or with Lurie, or if there's something that you think, this isn't a clinical thing, but like I know in the community where my patients live, this is something that could really help them, or this is a problem they're having, I would love to hear any of it and try to think creatively about how, I or people I work with can address those issues.
Well, outstanding. Well, I look forward to working with you more as we move forward. But for those of you who want to reach out to Dr. Marma, please just email her at amarma@luriechildrens.org with any of your questions. Or you can reach out to me, Chad Worley, the physician liaison for Lurie Children's in the north side of the city and north suburbs, Julie Kalkbrenner, the liaison for the west suburbs, and of course, Paula Nowak, the city central and south suburbs. So we look forward to hearing from you, and thank you again for joining us. And please join us again tomorrow at 7:30 a.m. As Dr. Kendra Ward talks about how fitness and exercise can help with preventative cardiology. Dr. Marma, thank you so much.
Thank you. It's great.
Everybody have a great day.